Dr. Kianwar Shah. Today we have a treat for you, and Dr. Marcelo Ferrer from Chile, Latin America, has joined us to bring some perspective from those countries, and we really appreciate it. Thank you for joining us, Dr. Ballard.
Thank you, my friend. It's an honor for me to be here with you and all the people.
Thank you. I'd like to do a quick introduction on your wonderful career that you have had over the years. Dr. Ferrer is very well known amongst implantologists and surgeons around the world. He has completed his undergraduate study at the University of Chile in 2000, where he received his degree in dentistry and a title of a dental surgeon. He received his postgraduate training at the University of Underbello with the degree of Master in Dentistry, specializing in periodontics and implantology, graduating in 2005, July of 2005. With almost 20 years of experience teaching in different areas as professor at the Faculty of Dentistry, University of Underbello, in the area of periodontics and implantology, both pre and postgraduate since 2003, and the integrated prosthetic preclinical department at the University Mayor. Currently working as a director of postgraduate program of periodontics and implantology in San Sebastian, the University of Chile. He participated in dozens of national and international courses worldwide. As an international lecturer in periodontology and implantology, he has performed live surgeries and hands-on courses all over the world. Dr. Ferrer is an active member of the Academy of Osseointegration, member of the Society of Periodontology and the Society of Prosthetic and Oral Rehabilitation of Chile. In addition, if that's all not enough, folks, Dr. Ferrer maintains a private practice in Santiago de Chile, which is limited to aesthetics, periodontics, and implant surgery, and prosthodontics. Dr. Ferrer enjoys tennis, golf, and spending time with his wife and two wonderful boys. So, Doc, what a amazing career you have had, and you continue to grow. I understand you were scheduled to lecture in Washington and Cancun, and that has fallen through due to COVID. Is that true?
Yeah. And a lot of more places, but you know, the world is closed for a reason, and we need to decontaminate the world a little bit. So let's take it like in a positive way. And
I love it.
Let's kick it from here, man.
Look at the positive side of things. People that are strong-minded always find the positives in difficulties and hard situations. Look at how clean the air is in some countries now, and look at the environment, and look at a reset, how much we have gotten to know our families more and our friends online. And there's been a lot of good stuff that came out of it. But with that said, how's the weather over there? In Chile?
It's we're in the middle of autumn here, but we are blessed because we have like amazing weather until so far. So, you know, in order to get things straight with the virus, this is the best thing that can happen to us. So we're very, very happy with it. It's going to be a rough winter ahead of us, but we're gaining time to be prepared for what's coming. So still we are waiting for the results. We are learning about every part of the world that already faced the critical part of this huge problem. So we're getting more responsible and wise about it. So it's finally happens to us. You know, we're a country with so many issues, earthquakes, social stuff sometimes. So we're known and we're used to be beaten. So finally, this gave us time to prepare better for this crazy thing, but we're gonna be okay, I hope. But it's gonna be tough the next months.
Agreed. Well, thank you, Doctor. I'm gonna go ahead and switch you over to your presentation. Could you kindly turn up the volume a little bit so the listeners can hear you just a little bit better? I'm gonna go ahead and yeah, there you go. There you go. I can hear you now. I'm gonna put this in the stream, and we will get started with this wonderful presentation. And hang on 1 second here.
It's perfect.
And then here we go. And you are live, and we'll take questions after the session. Thank you so much, Doctor.
Okay, my friend. Tell me if you see the whole screen
Yes.
right now. You see
Yes.
it?
Yes.
Okay. Well, first of all, I want to thank you for this invitation. I was really looking forward to. I always looking forward to speak about this subject. Either way, the partial extraction therapies it's here, and it's another tool to face socket extraction, tooth extraction, and socket preservations. I'm gonna try to show it from a different perspective, maybe than you may see it before. But for me, pathology is like a science of partial extraction therapy. So, and in order not just to speak just about the technique in the anterior region or aesthetic zone, I'm going to try to make the point that this is a tool that lead us to fulfill all the goals that we need to cover in full arts. So it's not just aesthetic zone. Okay, I'm just going to start giving that information. In order to start, well, for me it's a great honor be in one of those little pictures, little faces among those a lot of guys that are very close friends and people that somehow influence our career. I'm not that young, but for sure there's people there that deserve a lot of credit for what we are right now. So I'm very very humble and happy to be able to call a lot of those guys my friends and inspiration. So what we're gonna be discussing today, first of all, is a small introduction. This is a wide world, but we are just in this part of South America. We're so isolated now from the world, not from COVID, sadly, but we're very, very far away from everything. So every part of the world that I've been into, it's for me, it's a blessing, and sometimes the schedule is a little bit tight, but always we need to find time to explore the world and having very nice and decent and quality time with all my attendees to my private and courses or different meetings. So I'm very humble and thank you once again for this opportunity to be here with you. This is exactly what I'm looking in now. I have the sun straight into my face. This is Santiago. I'm facing the mountain where people are skiing, not yet because it's not the tough winter yet, but in a few months people are going to be skiing there and I'm going to be working, hopefully. But Chile is a very long and thin country, so we have in the middle of our country we have the the main capital, but we have desert in the north, rainforest in the south, Patagonia, a lot of vineyards in the medium valley. So we are 1 hour towards the mountain to the skiing and 1 hour towards the beach and wine cellars to go. We're also very known because we managed the way to bury 33 miners a few years ago. But the spirit of Chile and our tragic events that always occur to us as earthquakes and stuff that we were discussing, uh, we have a special way to look life and optimistically way to understand that we can manage every situation if we work as a team. It's not different what we do in dentistry. So finally, to rescue 33 miners 700 meters below or towards the core of the earth, it's a thing that makes us very proud of ourselves. As you mentioned, I'm a director of a perio implant program here in Santiago, and in the south we just opened a new program, and we have people from different parts of Latin America also that comes to study with us. But also I'm a director of a Southcon Chile actual education center that we bring live surgery courses and hands-on courses for the people, and we have the credits to do it. So it's very very nice environment. What we're gonna be now is going straight to the point. It's from a chapter that I always teach in a 2 or 4 day course that it's from socket preservation to alveolar ridge reconstruction. And not everything is related to aesthetic zone. I always try to avoid that thing. That dogma is like we're taught to go and always speak about the aesthetic zone. And actually, what we're gonna be discussing today is that we need to understand that we need to find and manage a lot of different rules, and those rules are made for not just the canine or a central incisor. Obviously, the molars are important too, and I'm going to try to make my point during the clinical cases for sure. One disclosure is that I'm not using any Photoshop. Okay, you will see a lot of pictures, but anything is Photoshop unless I put this signal. Okay, so we're not gonna do anything about Photoshop. Okay, so I mentioned before we're gonna discuss about partial extraction therapy, and in one Dental XP global symposium, they gave me this huge title like pathology, full arch maintenance. And pathology, I try to define it as a search, and the search is for these two huge and very big important words that are essential in our work. That is predictability and reproducibility. One thing is what we do needs to maintain or last for a long time, and on the other hand must be reproducible. So when I teach it, somebody can keep it in his mind, train it, and then achieve it. Try to achieve the same results that I'm going to show you. Okay, this is very important. At the end, you will have my Instagram account. You will write me if you have any doubts. Please feel totally comfortable of doing so. And if you want some of the articles that I'm gonna quick pass through, I'm not gonna stop there because we only have 45 minutes from now. So I'm just gonna go and make my point about this technique. But I want to be sure, and I want to let you know that if you write me, I will answer. It's gonna take me a while maybe, but I will. So when we have a tooth extraction, the reality is that if we don't do anything at all, we will have resorption. That's everywhere in the literature. If we don't do anything at this point, it's going to lead us here to the right side of the screen. It's going to be an atrophic bone, and we're going to have to do several things in order to try to achieve our first goal, to avoid dimensional changes. Remember, not just in the aesthetic zone, but it's the most important for the patient sometimes at the beginning. And we're going to have a lot of things going on. We're going to discuss some techniques that we use today before we discuss the ones that we're getting here together today. So basically, we have different approaches, and we can manage these results in a proper way. Or if we have the atrophic jaw, we also have another big surgeries that we can perform to ensure that we will have this predictable implant into the perfect position, prosthetically driven, as you see in these pictures. It's not the goal of this presentation, but it's the goal of the second part of the course that I mentioned about how to predictably rebuild this atrophic bone when we have to. Okay, so basically what I'm trying to say is that from the socket, we need to be able, or from the atrophic ridge, we need to be able to rebuild the site or avoid dimensional changes from the beginning. Preservation must come from diagnosis and planning before extractions, not after, and let's see what happens. Okay, that's the trend. In order to what? To achieve this important goal, to put this implant in the prosthetically driven position. So we're talking always about this obsolete, for me it's an obsolete concept about socket preservation. What we need to discuss is implant preservation. So we need to come and be able to join or merge these two concepts of avoiding the dimensional changes and rebuild predictably the site, as you see here. This is a CBCT, 5 years post-op. This is the day of surgery. This is 5-year post-op. Exactly the same measurements. So obviously, you will see these cases during my presentation. But not everything is socket preservation. Maybe here we did socket preservation, but the importance is to give implant preservation. For example, in this case, what happened if I try to put my implant in the proper position is right here? We not need socket preservation. We need to rebuild the site. So this is the exactly same case 1 year post-loading. So everything is about the plan. In order to have this plan, we need to understand what success means. And socket or implant preservation success means that we need to try to achieve these kinds of results in every case. Try to imitate nature, biological nature. This is a beautiful picture taken by a friend of mine and the sponsor from here, from Chile. And you can see the beauty of it. It's not even if it's teeth or zirconia customized abutments. This is what we really need to search. Try to integrate biology into prosthetics in a proper way. And you just gonna be able to make it if you started from scratch in the beginning. Okay? So we are used to call this success in the 80s. You know that all these parametrical success rates about not movement, a yearly radiograph loss, it's acceptable, no pain or whatever. This is, if it's not moving, it's maybe because we have 2 implants in a good, healthy way, but the rest is a mess. You can see from every single aspect, clinical aspect, that this is not success. And when you take this prosthesis out, you will understand what I'm saying. You can even have a perforation in the mandible that you can touch in the edge of the bone. And this is not success. Not even if the patient it's in a good shape or not feeling any pain. Okay, we need to change that. Or this kind of stuff. You can see this is not success. And we have learned a lot from the 70s and from the 80s when this started to get massive. Look how the tissues adapt even to failure. How faithful and loyal are these tissues. So we need to respect them. Look, if we drain some implants, you can see that it's not success by any means. Okay? So, but we live in this environment that is not easy to handle. We have the concept of sticky bone. I call this the sticky food. This is happening when we don't take the measures in the prosthetic as well. So integrate the patient and use the team approach. It's totally mandatory these days. And we can do great stuff. Way, way better than these ones. Okay? So planning is the base of it. But sometimes failure is not an option. And of course, it's not an option because we always discuss about the pink and white, the dual zone, whatever. And I'm going to try to take you out from there. And it's not just the anterior region. But let's start with this case in order to be more active. If I ask, sadly, I'm not in a conference room right now, so I cannot like go and point with the laser to the guy who's sleeping and asking where's the implant. But I think we all have an idea. So I always draw these lines to help the audience. So now everybody's going to pay attention for this side. So, they're going to say, if I don't see this crown too obvious, maybe I can go for this or for this one because I have this lack of papilla, right? So my first thought always is going to be that I have this implant here or here. Okay, so I always show, you're right, great, you know exactly the point. But always we need to find both sides of the story. And we need to go and dig to the past to see actually what happens. And when I showed the previous picture, surprise, we already have this lack of papilla. So what we achieved here was socket preservation. So it's doable. But how many things do I have to make? This is one of the most read articles from Team Atlanta about the distance between implants and the how much papilla I can get from the interproximal hyoid bone and stuff like that, right? But look, this fistula that was over there, the cyst, we took the implant out, we tunneled to not to raise the flap. We did the immediate implant, not immediate loading in this case. We did some connective tissue through this tunnel that we performed. We put some collagen membrane, bone grafting, healing abutment, and then an adhesive provisional. So finally, everything went to normal, but still we're not happy with the result in volume, but we're okay because the patient is okay because it was not complaining about this papilla. And after the treatment, the work was done perfectly because we maintain. If this guy wants this papilla a little bit down or coronally, we should think about maybe an orthodontic extraction in this teeth to bring this interproximal bone with it, and then we can have maybe the possibility to have this papilla back. Okay, so when we're discussing about socket management, okay, we need to define it a little bit in history. I'm not going to bore you with this history, but this is a picture took in the art museum, Historic Art Museum in New York, of the Neanderthal skeleton. And we, at that time, we already have issues with cysts and buccal plate. So this is a problem that we need to be solved like millions of years ago. Okay, so the literature is no way that you can read all the literature about socket preservation or tooth extraction or what happened when we have tooth extracted. But in order to understand it, you need to separate from tooth extraction, and other one is socket management. Okay, and to understand the concept that we're going to embrace today, tooth extraction has a timeline, and I'm going to just quick view just two of them. First one was the Araujo and Lindes study about the bundle bone. It was so important because we understood at this point, okay, that this buccal plate, this bundle bone, is related to the presence of the periodontal ligament. Okay, the nutrition of periodontal ligament is essential. So if we extract the tooth, and dimensional change is going to occur no matter what. Even if I graft, we will have some bone loss. And if I don't graft, as Nevins and Sands and Linde and other ones will show us that we have a lot of chance to get an atrophic bone within days. And I will show you in some cases as well. But the second one, it's the Kahn article. Joseph Kahn wrote an amazing article that is going to ring a lot of bells when we understand that he classified from the canine to canine more than 600 teeth and classified according to the relationship, anatomically relationship with the buccal plate and with the palatal plate. So we have the class 1 till class 4, and you can have that article. If you write me, I will send it to you. And you will see that the percentage of it are everything far from optimum. We have just the ideal socket is just the 1%. But we have the 81% totally close to the buccal plate and 12% totally close to the buccal and the palate. And this is very important in cases like when we find this kind of results in time, that we have not just the buccal plate missing, also the palatal plate. So this is very difficult to achieve, and we need to understand this before tooth extraction. okay? Because we are running late. What happened in this case is that we make the tooth extraction and we didn't have even a robust buccal or palatal plate. So we're going to take this tooth out, we're going to have resorption in both, okay? So we're going to discuss, and I'm going to try to focus ourselves in just this one question at the end of this lecture. Can we avoid dimensional changes? Can we predictably avoid this? And the answer, we're going to try to work it. But if we try to focus in just two things that we've been told and teach about, we have the Swiss team, Danny Buser and Urs Belzer, about to early or delayed approach plus GBR, or we have this American team of Stephen Chu, Maurice Salam, and Dennis Tarno about this immediate loading or immediate position of the implant, that what they called dual zone therapy. So if we try to go very quick into the first concept about the Swiss team, we will find that they do the extraction. They let this socket heal for 6 weeks, 6 to 8 weeks, in order to achieve more soft tissue, to go into the second surgery and do my bone graft, my implant position if you can, membranes and all the GBR procedure, but you have a robust soft tissue to cover it and do a tension-free closure without issues, without problems, without morbidity, and they work for them. And after 6 months, you need to go and unbury that implant, put your healing abutments, and you start doing your emergence profiles and working on them. And finally, at 9 months, a year, you will have, at the best timing, you will have your final prosthesis. And this work perfect for them or for the people that follow that philosophy. It's one golf club of many in your golf bag. And what says the American team as well? It says, you know what, in type 1 sockets, you are going to be able to do both. Even if you have enough bone, you're going to be able to load this implant and manage the emergence profile from the scratch, not by imitating the dental shape, but to understand it and honoring the prosthetic implant or the implant prosthetic that is different shape than the tooth. And we need to respect this because we have tissues, biological tissues, to deal with it, not just soft. Almost obviously, we need to face the hard tissues as well. So this kind of procedures, we can have at 3 or 4 months the final prosthesis. It's more like the dentistries here in Chile. People doesn't want all the time to maintain and have multiple surgeries, not even can afford them. But sometimes this is better for people, and obviously sometimes it's better for them the other way. But we have those, and we've been teach about this too. We prepare ourselves, we learn it, we work with these techniques, we make hands-ons with the techniques, and now we teach them. So we cannot stop searching for more. Just to make my point clear, I'm going to show you just a dual zone therapy case. Very quickly, we have a fistula over tooth number 2.1 or 9, if you want to call it that way. First of all, we're going to take the infection out. I always try to change from a catabolic to anabolic patient, or just the site, because the response is going to be better if we clean this up first. And we have the tooth extraction. Always find my way very close to CSI movies. You know, CSI, when you go and try to like do a private investigation about everything, what happens and why can I learn about the extraction. So always take 5 minutes to see and learn what's going on in biological tissues, and when you have fractures, what can happen and what can be wrong. So what can I do to try to fix this later? Okay, so we have the extraction. We cannot do anything else about the extraction in this case. So we're going to put in the perfect prosthetically driven position. This is not prosthetically, but this is the trick to go and attack the palatal wall. And then you change the direction when you have the top of this drill it is stable enough to change my angulation. You can do it without a guide if you're heavily trained, or if you have heavily trained, you can go and use a guide as well. In this guide, we use a guide as well, not the strict guide, but we use any you can use any splint as a guide. Okay, but this implant is in the perfect prosthetically driven position. In this case, we're going to use dentin. We extract the third molar and we use dentin as an autograft, and we have the best experience with dentin grafts in time, and the results are quick and amazing. It's not the main goal of this lecture, but just to show you, when you treat well with your provisional, even it's not the most aesthetic provision, because you sometimes you don't have the resource to send it to made, or you have a limited resource in the place that you're working, that you have just acrylic. It's not an excuse to make a fully functional and supported provisional. So this is day 0, just 5 minutes after we end up the bone grafting. This is day 7, and you see angiogenesis in the fistula zone, but also you can see the amount of detail in the volumetric scale. Look at this splinting; it's beautiful. This is healthy. This is a very nice result. This is 8 months after. This is 1 year post-op, 2 year post-op, 3 year post-op, and you see exactly what happened before and after. I love to show you the exact same pictures. I took time in surgeries to try to take all my pictures, and I create a mess with the cameras to get it sterilized, but it's the best way to show you. This is the same case, no Photoshop. This is 3 years post-op. And yes, we can do it. We can avoid the mental changes by these things that we've been taught. Okay, look at this case. Nothing to do in this case as well. So we put the implant perfect position, and we have a lack of the buccal plate in the upper part. So we use the cone technique membrane in the dual zone therapy, and we used like common, in this case was minerals. It was cortical cancellous bone, particle bone. And then we use the same provisional, the same tooth as a provisional. As you can see, we imitate not the tooth of the shape of the tooth, but the shape of the implant prosthetic device. Okay, we polish it and we put it in order to have the perfect result. And this is 1 year post-loading, and the tissues looks amazing without anything else than just a graft. Okay, so the question again, can we avoid the mandibular changes in time? Yes. If you're Danny Boozer or Maurice Salama or Dennis Darnold, for sure, mostly in every case, but you need to be very prepared. It will cost you a learning curve for sure, but you will be able to do it. Okay? For sure you can. But this is the question. How much biological effort do I need to achieve this? And how much biomaterials I will use to achieve this goal? Okay? So don't forget this, because we're trying to be predictable and reproducible. So is it predictable and reproducible, those techniques? When you challenge biology, my friends, you have more risks. Not less risks, more risks. So what we are going to try to discover now that I'm going to concentrate myself in partial extraction therapies is to try to change that a little bit. So if we're going to the big bang of partial extraction therapy, that's for you to understand that I try to look the big bang. So this is my vision of big bang. Okay, so we're trying to understand the partial extraction therapy beginnings. We need to go and dig about history and dig in the past and find the importance of root potential. And obviously we all have this old cases about the attachments with the removable prosthesis attached to this structures that we cement on the radicular remnants. And of course, we can understand that sometimes you got this root submerged just without knowing, and you have robust amounts of bone. But for me, this picture took by a student of mine in a pre-graduate school, I understood what potential radicular potential means. And if you see that this is the mesial first molar root that was self-extracted in time, and you have just bone where you have this periodontal ligament, and you have maintained the height of the bone and the width of the bone in that area. So you have bone loss when you don't have tooth, and of course more periodontal risk because you have plaque, you have a calculus that you need to take out, and you have depth to go and deal with it. Okay, finally you have chronic disease and you have bone loss there. Okay, but this is the amazing part. When I have periodontal ligament, even in these extreme cases, I have bone. So it was this paper that was created with Team Atlanta in the 90s. Imagine more than almost, it's going to be 30 years soon. They use submerged roots to treat aesthetics prosthesis in the anterior region. So they use this that is way before them. They just apply it and publish it to everybody know it. What people have discovered in the past about submerged roots. They were submerging roots from the 30s, the 40s, 1940s, but they embraced that concept and they submerged these roots with the objective or the goal to not lose interproximal higher bone and not losing the buccal plate or the palatal plate in the class 4 as Joseph Kahn classified those defects. So this was like a 10-year-old root submerges that I just tried not to do anything else but stabilizing the clot with the prosthesis. And from this result, 84 months later, I had this result, and you cannot see any dimensional changes in the soft tissue, but maintaining this interproximal higher bone, even with this implant in a very coronally position. If I took this root out, this may fail for sure, as you can see in this radiograph. The bone loss is almost, because if we embrace Thomas Linkevicius' work about the zero bone loss concepts, you need to know that you need to have a certain amount of millimeters for this biological width to maintain. But when we have this root, we maintain this interproximal higher bone either way. So it's going to be beneficial for this implant as well. Happens in the two sides 84 months later. So basically what happened is that Marcus Hurseller from Germany says to Maurice, and the story I've heard it from the very true actors of this story. Listen, you give me a very nice idea about your root submerging paper. I will come out with something very important. That's the start about socket shield. It was a brilliant idea because, you know, if I can maintain a whole root, why cannot maintain just the buccal portion that it's so related to the maintenance of the buccal bundle bone? So basically, they start a new concept by maintaining this root. And what happened with the implant and the dentin, they found bone between the threads. So basically, this concept started from the root submergence. You can see this is the root submerged. This is the crown like a pontic, okay, on top of it. Then Marcus Hurseller about the socket shield needs to be an implant and a tooth, obviously, to call this socket shield. But what happens if I need, or I don't want to put an implant. I want to use it as a pontic, but I have a fracture, or I have a apical disease or a cyst. I can use the best of two worlds. I can create the socket shield and graft it. So that's what they call now the ball went back to the other side, and this is the pontic shield. So basically we have root submergence, socket shield, and pontic shields, and all this together, it's what Howie Glockman, Maurice Salam, and Jonathan Dutoit published in 2015. And finally 2016, about partial extraction therapies. The way that we need to think this is that now we have a rationale, and before extract any tooth, we need to stop, think, plan, and then perform. Okay? And that's what I will show you. We have more and more literature coming on. We have almost 10 years of experience in this field. And we have also human histology. This is a courtesy of my dear friend Chuck Swimmer. And even we have this multi-centric, multi-language, multi-country, amazing dental pet research group that I'm very humble and very thrilled to and honored to be part of, working side by side with the most amazing human beings and also clinicians of the world, very renowned, very important guys from all over the world, and dear friends. Our WhatsApp chat can't even write a book by itself, but these guys went fast and create amazing book. They're from India, very nice close friends that we were very happy to collaborate even with them and as a group, because we are very proud of them, and I feel very proud of being in such a very important group. We also have in 2017 the first PET consensus. It was in the GTI in Madrid, a very nice meeting that organizes by my two dear friends here, Jorge Campos and Juan Alberto Fernandez. And of course, it was an amazing event, and we create all the things that you will see now step by step. Obviously, now we have different PET kits. This is one of them. Now we have a lot of different PET kits. At the beginning, we had just the regular burst, so we needed to find a way to make this technique happen the best way that we can. So we're gonna just quick go for this overview from the technique before we're gonna crash into the clinical cases, okay? But first of all, we start with the decoronation, about the remnant of the tooth that we need to extract. Obviously, we need to understand that we need to have a decent indication about the extraction, because nothing is going to replace a regular tooth, okay? Nothing. It's going to beat nature. Okay, so we're going to take a round-ended cross-cut carbide burr, and we're going to use it like this that you see in this video, okay? And this animation. All these are my animations, so I can send that to you if you write to me. To my Instagram account, it's going to be at the end of my presentation with no problem. Okay, finally, what you have is a root inside of the bone margins that you can work without a problem, without or diminishing the risk of fracturing, and obviously luxating in a bad way. So the second part is when we split root mesiodistally. And we're going to use the same burrs that we used to cut the tooth, or just the carbide tooth, or the big diamond burr, okay, through the endodontic channel towards the apex but always taking the apex out. This is very important. This is the occlusal view, okay, of the fracture. And when you understand your CBCTs and the root that you're treating, this is going to be easier and easier case by case. Okay, and the thing is that you need to understand is like you see in this video and in the animation. Look, when you go through the canal, okay, don't go on over it, but if you have bone, it's not going to be a big deal. It's an osteogenic defect, nothing's going to happen. But then you need to go through the distal and the mesial coming up, like you see in this animation. You go through the channel, and then you take the neck of your drill or your burr mesially, while the top or the tip of your burr, it's distally, and you go this way. So you're trying not to damage. When you have too much radicular proximity, you don't damage the root next door. Okay. The other part that we need to understand is the removable of the palatal root section. So we need to luxate it, and always we need to luxate this from the palate or the most stable part next door, which is in this case this tooth right next door. Okay, and if you see the design here, it's different, the design mesiodistally when I have an implant that when I have tooth. Here I have interproximal bone, higher bone. Here I don't have much. I have much because I have this tooth, but when I take this out, I will have problems. So what's going to happen here? I'm going to extend this shape a little bit longer in order to maintain this papilla, because I have this implant. If I take all the tooth out, this implant will have problems in the future with this papilla. Okay, so what are we going to do? Luxate it as you see there, and then we're going to take the root with the apex as you see over there. It's very important, very critical that we take the apex out, because we don't know exactly what happens in that apex, if it's contaminated or not. You cannot go with the procedure without knowing everything that's going to happen there, and this is a highly risk of morbidity, and I don't want to do it. Okay, and we can avoid it easily if we do the right plan. So basically, we are here, right? We took the palatal portion or the lingual portion of this. In this case, we're going to reduce the root shield 1 millimeter above the crest first. Okay, we're going to do it with a round burr, as you can see here. Okay, this is the way that I do it, because obviously in Chile we don't have all the tools, but you can also protect this soft tissue by some handlers and membranes and metallic membranes that you can put there. But look what happened here. I'm using the same shield as my protection. Look what I'm doing here. I know that this drill is 2 and 2.5 millimeter length and wide. So now I took it, boom, and I protect my root, as you can see, and then I extract this part. And after that, I'm going to cut and reduce that shield to the crest of the bone with an end cutting burr. Okay, so if I take it with the round burr, I'm going to have this widow's peaks, and I will take this out as well with this drill that I think that this is very important to have in this kit. And after that, I will chamfer this according exactly to what I want to achieve. And in this case is to create 2 chambers, the osteogenic chamber first and the gingival chamber. We're going to have growing from soft tissue, either in this part we will have of hard tissue. So first it's going to form the soft tissue, and then we're going to use help of some bone grafting. Sometimes when the gap it's more robust, we're going to use, or we have to graft those gaps in order to don't have this ingrowth of bone tissue, because it's going to obviously grow faster than the bone. So this is actually a real view of a molar shield that you have there. Okay, even if you don't be able to do immediate loading, you can customize your abutments and maintain this ready for later. So if we have these key point measurements, we can go horizontally and vertically. And horizontally, we have the C shape that I mentioned, and we have the width of the socket shield, not more than 1.5 millimeters is needed. Okay, the more you have implants here, more you have to extend the C shape. Okay, the gap, if you have more than 3 millimeter gap, 2 or 3 millimeter gap, graft it. I use NovaBone here always in most of my cases to stabilize the cloth. It's very important to stabilize the cloth with something. Okay, try to maintain biology safe. Okay, and in the vertical point of view, it's important to understand the length of the socket shield. Always try to maintain at least 2/3 of the length. Okay, obviously we need to go with the distance from the gingival margin to the socket shield. Ideally is have 3 millimeters. Okay, ideally. Look, the way that this burr doesn't damage at all the margin, the gingival margin. Okay, obviously from the crest to the socket shield, to the bone crest, and to the implant towards the socket shield crest. We need to understand that depends on the connection of the implant. I can vary a little bit more the implant or not. Okay. And now I'm going to show you the cases, and I choose and I picked some cases because every case must teach you something. Okay. So we have cases that are going to show. I'm going to show just one implant case, couple of implant cases, and full arch as well. Okay. So we're going to start with my dear friend Hugo. And this is an amazing story because this was not even restorable. And this is a very close friend, a former tennis player that I played in junior when I played some tennis in my past. And he was like totally into try this new technique, the socket shield. So basically at that point, we didn't have the tools that we have now. So we create these T-shaped fractures to try to luxate these two walls, not to from here, but from here to try to take the roots out. And it worked. We took this little lesion, apical lesion in that one. So it came out with the extraction. We put our implant in the perfectly prosthetically driven position in the palatal root. And then we graft the the gap just to stabilize the clot. And I obviously don't have enough stability to load this implant, but I use this restoration to add some Maryland bridge and use a fixed provisional. Always try to use fixed provisionals because it's very imperative that I maintain these papillas support enough for them. And look at the result of 30 months. Look at these tissues. 30 months, 48 months, 60 months. And look the sagittal view. Remember, Maryland bridge, maintaining this papilla and this papilla, and obviously giving support and stabilization for the clot. This is 3 months, 11 months, 2015, 30 months, and you will see 38 months, 67 months. What do you see? Basically, what do you see next door? You can see this amazing, robust tissue here, but it's a very thin phenotype, gingival phenotype next door. So everything was going up except of this part when we change this biological width by gaining more tissue going inside the socket. So basically, when I have thick tissues, I have stability in time. Everything is going up in the same bite, the same brush patient. It's a heavy brusher, I don't mind. But why I don't have any changes here is because I have different quality of tissues. Okay? So this is not a joke. So we need to understand that gap management is essential to maintain sometimes and change this biological width. This is a nightmare case because this is 3 months before this guy's going to get married. He's a hockey player, very talented, so people want to hurt him because he's so talented. And they kick very hard with the stick in his mouth, and they broke not just the lip, that it's important as well, they broke the central incisor, the canine, and the lateral. So I'm going to use this lateral thinking in my provisional, and I'm going to try to see what's the shape of these fractures, and I'm going to use this as my socket shields in both of them, put the implants, and obviously I'm going to drill a little bit this one to support the provisional here, and with the occlusal support in this premolar. And we're going to put our healing abutments, Nova Bone, to stabilize the clot. And after that, just 40 minutes post-op, my provisional supporting the tooth number 10 and 12. This is 3 months post-op. We need to do the endo at this point. And of course, this is 3 months before getting married. You see that even he shaved. And this is before, this is in a bachelor party. He sent me this with the provisional out. So he put it up again because I told him the importance of not having this loose. So he put it back, and he was very obedient. Even I have the authorization in the WhatsApp to show this picture. He's just when he was in the bachelor party. It was so funny. But you see the tissues. This guy's ready to get married and happy because at least now he's going to get married with screw retained provisionals, as you see right here. This is exactly 3 months, and this is 14 months after. You can see the beautiful tissues and the maintenance of these dimensions, occlusal and frontal views, for you to be totally delighted of seeing this. It can be better than this. So what do we learn in this case? That we can stage this socket shieldings. Not even with this, we can also stage this procedure with customized healing abutment that I will show you in some cases. And we can definitely maintain this native architecture that patients have and have these aesthetic results. It can be better than this. And a place that for me is one of the most difficult places to work with is the lower incisors, because everything resorbs there. Everything is so little. We don't have much place to put our implants. So this is the two centrals I will show you. This is way a lot of years ago when we don't have those atraumatic bursts. And when you get distracted, you commit these suicides. Very terrific things, but don't take this pedicule. Just position this here back and use the provisionals if you're going to use it, or the provisionals cemented to the roots next door. So in this case, this is going to be at 3 months immediate post loading case, 12 months. Look this part, please. Look 40 months. Even I changed my camera at 60 months. You can see this is a brand new camera that I have now. 60 months afterwards. And you have the provisionals here. And of course, radiographic levels are perfect. So what do we learn in this case? That this is technique sensitive, not topographically sensitive. So we can do this and transport this information to other parts of the mouth. And not everything is aesthetic zone. So I introduced you to the first molar in history. 2013, my dear patient Javiera, that believed in our concept, I performed there in 2010 root submergence to this patient. So she knows about these kinds of techniques. And now that I can maintain some part of the root, she was thrilled. So what I did was trying to take all the molar lingual parts out, but I got loose the distal root. So I was hopeless. I said, okay, I'm going to take this out, and something told me not to do it. And I said, you know what? This is perfect. I'm not going to do anything. I'm not going to even going to graft it. I'm just going to maintain this root and see what happens. This is my only case that I didn't graft a socket shield. And look what happened. This is the root. This is 0 hours. 44 hours, the clot's stable. This is 72 hours, 3 days later. This is 288 hours, 14 days later. And you see here, it's not the shield, it's a sesame seed. You know, sesame, that one you put in your rolls? Sesame. So my patients don't eat more rolled seeds, no more. But this is healthy tissue. But look what happened. In the 14 days, I have this groove right here. This is collapse of the top part of my socket. And you can see very clearly here. So what happened is after the 3 months, I started to rebuild this side with the provisionals, okay? To try to gain a little bit back of the tissue here without doing any surgery or connective tissue graft. But look what happened at 3 months, 24 and 36 months in the CBCT. Let's draw a line in the mesial where I have the shield, medial where I just don't have it, just the implant, and distal where I totally don't have the socket shield, the one that I missed. And I draw the same line, the same measurement. And what I see, I'm going to just put it bigger, 0.8 millimeter loss in the middle one and 0.2 millimeter bone loss in the distal one at 36 months. So this is enough. Maybe you can say that this is not important, but let's see it clinically. Or what happens when I do or run an occlusal view. You can see that I have clearly a loss of volumetric stuff in the bone. And you can see that I have also a soft tissue collapse there that I manage a little bit with my emergence profile. Okay, this is when my patient has 4 years at that time, then 5 years, now he's 6 years and going to the 7th year. I need to call her back for the new picture. So you will have a year we did the final prosthesis, and you can see 2014, 15, 16, 17, and I have to take the 2020, but not with COVID going on. And what do you see? I'm going to try to, what do you see? You see a recession where I don't have my root. So at the impact, it's so important because I have more risk here than in the mesial part of having foot trapped there. So what's the foot trap? The beginning of bone loss and a beginning of problems. Okay, so basically what I have, and I told you I'm not going to use Photoshop until now. And I'm going to just press there. And now I'm going to duplicate the mesial and distal parts and bond it together. So the place that I have socket shield will see like this. And the place without socket shield, it's going to be like this. Siri's believing that I'm speaking to her. I'm not speaking to her. Quiet, Siri. So now I have this here. And I ask you, what do you prefer to have? A duplicate of the distal portion or the mesial part? You see this amazing quality of tissues, and you see the poor quality of tissues when I don't have. And everybody has patients with old implants that has this kind of tissues, no bone, no buccal plates, no best keratinized and attached gingiva in the buccal. So if I don't have that, I don't have the perfect sealing of the implant, and I have periodontal problems. So another molar is very, very impressive is this case that I started to work in this case in the analog way by creating a little bit the casts, trying to maintain the papillas that I want to maintain in the sagittal view. So I create this I know exactly where I'm going to put my graft, my implants, and I started the whole protocol with the decolonization, then to go to split mesiodistally, taking the the shields towards the margin of the bone, the crest bone, like you see here. You almost don't see when they are finally prepared. You don't see the shields mostly. You can see it right there a little bit, but you must have difficulty to see it if it's good or well done. You can see obviously that I took the apexes out. Then we put the implants in a perfectly driven position. We use the provision that I have already custom in the analog way. We can do it digital way. This is 3 months post-op. You can see even a little bit of an ingrowth on top of the customized healing abutments. And this is 3 months afterwards. You can see the perfect animation of the whole process taken by the same picture. And you can see this is 3 months. This is 0, 3 months after you have that one. And in the sagittal view, this is pre-op, 3 months with the provisionals and without provisionals, ready for final prosthesis and 2-year post-op. So basically, we have maintained the whole papilla in a very difficult site with the keratinized, robust tissues right next door. Okay, so now a quick, very difficult Pontic shield case. Okay, it's a common thing that I use in this kind of cases, intrasinus cases. You will see this very often, and you need to take out these roots. What you expect in this kind of procedure, you expect resorption. So what I did, first, one miracle at a time. Before going to the sinus, I will keep my shields as a Pontic shield. I take these roots out, I put my nova bone to stabilize the clot, and use these teeth to put the fibrin on top, double layer of fibrin with a cross suture. And this is my, after Marian bridge I put in the position, I have this robust bone to go and do my socket shields. So here you have another case, and this is what I'm trying to avoid, this reality. Okay, one is the lack of bone vertically and horizontally. So what do I have? I have this, I have my shields. This is another case, look the same, but it's another case. My bone, my preparations to my Maryland bridge, my cross suture on top of the fibrins, 2-layer, my ridge, and look what happened. I have it built it before in the cast. So it's very easy to put it together afterwards. So what I have, exactly what I tried. And then I have my second surgery, my sinus lift surgery. It's the moment when this partial Pontic shield is gonna become socket shield, as you will see right now. You see how robust I have the bone. No bone loss because I didn't took the tooth out. I just maintained the buccal portions of those roots. Then I did my lateral window, put my implant in the perfect prosthetically driven position. This is the way that I love to put the Nova bone because it's amazing and very helpful. And you will see here is the shield, here is bone, and here is my implant. So now it's socket shield again. It was Pontic shield here. Now it's socket shield here. Then I wait 6 months, and this is the CBCTs after my first procedure, okay? When I have just the shield to maintain horizontally. And then socket shield and my sinus lift procedure. So I have the best of 2 worlds going on. This is a case that I want to publish in the case report because it's a very, very, very clever, I think it's a very clever approach to do this. And roll technique to take a little bit more robust amounts of bone. Every surgery is an opportunity. Final prosthesis in shape. So now, multiple cases. when I use everything, every tool. Look what happened in this patient. 2 packs a day cigarettes. Look what happened 120 seconds later. I have this situation. I took an impression, and by the prosthesis decay, a lot of things going on here. Look what happens 4 months later. I had to do some GBR here, and look what happens when I started to recreate the emergence profiles, adding a little bit or resin or acrylic. So from here to here in a smoking patient, because the smoking patients here, we cannot say no to them. Obviously, we teach in peri-implant residency to try not to or diminish the amount of cigarettes, but the reality is that not all the patients do that. And for me, this is a way to challenge it, and they are responsible for what they do. But also, you make this very huge consensus about what is wrong, and you cannot do it ideally. But after you explain, they don't care. Most of them, others they care, but not everybody. But the concept is I'm challenging lot less biology by doing these procedures. So maybe even it's an indication, and I just leave it to open discussion later if you want. This is another case. Look at the soft tissues, focus to understand soft tissues. And please, in this case, heavy smoker, I don't want to do sinus lift in this guy. So I have to tilt the distal implants, so I cannot have this root if I want to tilt this implant. So I did Pontic shields here to have the buccal socket shield and cross my implant just behind it. Okay, and I have root submerges in the place that I can, and look the results, and socket shields in the rest. Socket shield, root submergence, socket shield, as you can see right there. Look the results, 2 packages a day cigarette patient as well. Look at this, marvelous papillas and healthy tissues. Look at this robust tissues, stable and predictable. Look at this. Actually, it speaks by itself. You can have FP1 kind of patient. This is a 3 packets a day cigarette patient. We have a huge infections on the 2.1 or central left central incisor. Fistula. We do the periodontal treatment. We put implants, graft here. So we did like boozer here, and we did like partial extraction therapy in the rest. Look what happens. GBR, marvelous tissue, root submergence, socket shielding, and Pontic shieldings. Look what happens here when I started to develop these emergence profiles. So I have these results in the first. Look at the results after a year in this kind of patients. It is quite amazing, right? Or look at this case. After I treated with the orthodontics, we have socket shields here and here. We're gonna do a full arch after periodontal problems, mobility of tissue. We treat mobility, we treat everything. It was very complex to understand this case. It's a case for a whole lecture, but you see the pulps, amazing, these pictures. I took it, it's one of my favorite pictures. I put the implants here, and then an adhesive Maryland bridge from the lingual to maintain these tissues, as you will see here. And 3 months later, I took this out, and I'm gonna root submerge this to maintain this architecture. These are healing abutments, and I have already took the impression, as you will see later. And you can see that I'm trying to maintain this. I don't want to do gingivectomies to maintain everything. No, I want to maintain what's the nature of the patient now. 0 hours, 2 minutes after the surgery. This is 3 days post-op. This is the occlusal view with the healing abutments, impressions, how I customize and maintain the papillas. This is root submergence. And this is the result. 72 hours, 6 weeks. Look at these tissues. How beautiful these tissues are and how they maintain the stability of the region. So basically, can we avoid dimensional changes, guys? And I'm telling you, we can. And we have different tools in our golf bag. Okay? But in order to do this kind of procedure, we need to understand that we can have complications. And we can have two major ones: external or internal connections. Internal connections maybe be in the inside of the preparation, and external are gonna be in the outside. These are the surgical pictures, and I have some lesion before here. I didn't wait much, so the tissues were not able to support this biological challenge and collapsed a few months later in that particular point. Not in the medial, but in the distal. So what I did is what I do in every complication that I have it at this point, internally or externally. Just drill this. If the shield is robust enough, this is not going to be any movement, no sign of infection. You need to address that. No periodontal pocket, okay? No pocket depths that you cannot manage. I just took around our cylindric diamond burr, and I took some tuberosity tissue and just put it inside of the envelope, and that's the deal. This is the most complex complication that I have. It's very easy, and it was my fault, not the patient. I should have done this in the beginning because I knew that I didn't have the best tissue here because I have some little abscess. Okay, a little fistula before the surgery. This is 1 year post-op, and you can see the robust tissue that I have there. So what do we learn in this case? That complications may occur. As I was mentioned, we have this early and delayed Danny Buser, Urs Belzer approach, or the dual zone therapy of Stephen Chu, Maurice Salam, and Dennis Tarno, and also this Gluckman, Salam, and Dutoit partial extraction therapy. Please, I'm saying that this is better than that one and that. Listen, this is 3 of other many things that we can do to try to achieve the main goal, that is stability for our patient. Okay, so what do we learn in this whole lecture? That nobody owns the truth. Every personal treatment, every treatment needs to be done by nice or a good amount of planning and the adequate planning. And of course, it's one best treatment for each patient. It's not a recipe. It's not a copy paste. Everything is different. Every patient is different. Every tooth is different. Every region of the mouth is different. Okay? So what Aristotle says, we are what we do day by day. So excellence is not just a way, it's not just an act, it must be an habit. Okay? So I'm going to say thank you guys for this opportunity. Here is my this is the Patagonia and the glaciers in the south. This is my Instagram account. You can write there. It's way more easy, or you can take this screenshot, and I'm open to questions. For anyone that are welcome to my country. It's not mine. It's from 17 million Chileans, and you're more than welcome to join us anyway. Not even in my training center. If you want a very nice tourist guide, I can obviously provide some good information and know better my beautiful country. Thank you very much for your time.
Thank you, Dr. Ferrer Bellart. Much appreciated. You have a few questions, if you don't mind me asking.
Of course.
So the first question here is, can we remove the whole tooth and then place the cut portion to the buccal bone?
No.
No.
That's why I use the burrs. The burrs are to maintain intact. The main goal of this technique is to maintain intact the periodontal ligament. If you take the whole root out, you disrupt this periodontal ligament, you fracture the, and you take that ligament out. So you take the blood supply out and you kill the buccal plate, the bundle bone. Basically, the two first millimeters are going to resorb immediately. Immediately. If you don't do nothing, it's going to be more. But those first 2 millimeters are going to go immediately.
Also, take a look at the question below. Thank you for that. Do you use, Dr. Gupta was asking if you use a membrane between the graft and the gingiva?
No. The first two cases that I showed was to show what we know before partial extraction therapy. It's like the Swiss team and the American team about different ways to manage socket extraction. And when I don't have buccal plate or I have just a small rupture, this buccal bone, I can put a membrane. But I cannot do it. I'm not doing partial extraction therapies. I'm doing dual zone therapy or delayed approach or early or delayed approach by the Swiss team. But the thing is, if I'm going to do GVR, is one thing. If I'm going to do PET, I don't need any membranes. I don't need it because it's going to be a huge osteogenic defect that is going to be maintained by the interproximal hyoid bones and the papillas from the buccal plate that is going to be present because the shield is there and the periodontal ligament is there, and the palatal plate because we are waiting that have a robust palatal plate and we have the best soft tissues in the palate. So I have the best quality of keratinized attached gingiva is in the palate. So the less expect resorption is going to be the palatal one, except in those class 4 types, as Joseph can marvelously classify.
Wonderful. So on the case that you were showing, the braces weren't done, and we have this debate a lot in implantology. Do you wait for the braces to get done before you put the implant in? What is your thought on the case you were doing, and how did you finish it before the ortho was done?
Listen, this ortho patient, it was a funny story. If we have time, I can tell you it's very quick, but it's a very close friend of mine, also dentist, that he retired from dentistry and started building stuff. So he trusted me about this because he has a historic periodontal disease, and periodontal disease is one of the contraindications of this technique when it's active. And it was a very nice case because first I had to get rid of this disease for a long time. After that, I had to go from the molars working to the mesial to try to put every tooth in the perfect position before I have the shields, molar and premolar each side. And that was the last part of this patient. I'm just talking about from the canine to canine, and then we're going to submerge everything and going to do just a full arch. And now I'm trying to convince him to maintain, because he responds so well to periodontal treatment, that we're now trying to do 3 different prostheses, the anterior one and then the posteriors separated, and maintaining the guides with the occlusion guides from the canines. So we are maintaining them because I have this guy with provisionals for a couple of years now. So we are expecting that everything is stable. But the meaning of this orthodontic treatment was thought to do a complete arch socket shield case or partial extraction therapy case. So it's not like I interrupt an orthodontic common case and start doing socket shields and root emergence, it was everything think together and bring into this long-term, predictably and reproducible solution. So the fun part was, it's not like a common part, but I have other patients that I have indications of orthodontic treatments that I have to wait longer for ortho. Sometimes I can do the shields, and then I can use those implants to support the orthodontic elements, to bring other tooth back to them, and basically I have different cases with ortho. But this was important just to mention that we can use ortho in favor for our final expected case in partial extraction therapy.
Excellent. So, Doc, we're running a little bit out of time as our next speaker is in queue. Two questions I'd like to ask, if you can formulate a rather short response to them. What bone do you use to the graft between the gap? What type of bone do you use? A. The second question that was interesting was, how do you deal with infection?
Well, until now, I'm gonna answer the second one first, because I'm gonna forget it later. I have, in almost 7.5 years, I have 0 infection. 0. Promise. 0. And I have just 2 cases that I lose the implants. But one of them was because I loaded, not being able to load it. I just pushed the envelope a little bit. And the second one was because my mistake as well, because I didn't pay attention to occlusion when I loaded it. So I have this. I always see my patients a lot. Like, I mean, a lot of times. I don't charge for my controls, so I see them a lot. So they free, they come. Okay, so I don't charge for that. So I see, and when I see, the thing is, when you are able to realize that you lose the integration of that implant, you don't lead to infection. So I was lucky enough to see those implants fail at 3-4 months each. And I took them out, and then I thought, okay, I have to remove the shield. And if I have to remove it, I have to graft it. So those are the risks that you take. But for surprisingly, it was so attached. So I cleaned the shields again. I cleaned them up. I put graft on top of them. And after 6 months, I came again. So from socket shield, I did Pontic shield because I grafted, and then I shielded back with an implant, and they are healthy to the older one, 1 year post implant positioning. So basically, I don't have infection. I just have two implant losses in the socket shield places in which I couldn't be able to take the socket shield out because it was attached enough to graft it again, clean it again, and graft it again. If the graft or the socket shield is loose, you need to take it out and graft. What I use to graft, the first question, when my when I don't have much gap, I use the NovaBone is calcium phosphosilicate. It's like a foam that I use, a very nice product, and help me to stabilize the clot, and it's enough. Comes in little cartridges of 0.25 cc, so it's very cheap. So you use it and you stabilize the clot, and you cover up with the fibrin and with your provisional, even if it's Maryland Bridge provisional. And when you have more gap and you don't want bone ingrowth or soft tissue ingrowth, you can use dentin, that works amazing, or minerals, or is cortical.
You mean the dentin graft? You mean the dentin, the
yes,
grafting?
Yes. I use the Comet Avio Smart Grinder, and it works amazing. It's an autograft with the low resorption rate. So
I hear it heals faster too, right? It heals pretty fast.
Faster. Actually, and when you open the site, you don't see. I showed the case at the beginning. I show a case that I showed the 3-year post-op and the marvelous with the classic technique, with the dual zone therapy technique, with the dentin. It's the same with the socket shield. If you put it, you can ensure that you will not have soft tissue ingrowth towards the threads of the implant. So if you graft, you protect the ingrowth of soft tissue inside of the socket.
Excellent. Wow, doctor, so much information. This was one of the longer presentations with a lot of questions and answers.
I told you before.
It was wonderful. We have had so much interaction. Perhaps maybe you can go into the thread and answer some of those questions yourself as well for people.
Yeah,
but
please, as I showed my Instagram, because I have the scheduled thing going on. I know that I'm late, but the thing is, please, everyone, please write me and I will answer for sure.
Thank you. So with that in mind, please reach out to Dr. Billard on his Instagram page. I thank you so much for your donating your time and efforts to help educate and train and inform our colleagues from around the world that otherwise don't have the access or the finances or locked down with this COVID. So we're all trying to up our skills and up our knowledge so we can better care for our patients and reduce this silent epidemic known as edentialism around the world. And the only way we can do this is by increasing our knowledge. So here it is. Here's the resource. 100 people are coming together to bring this for our to our colleagues. And feel free to tune in daily on Facebook. For those that wish to earn CE, there's a separate process to be performed under gi-summit.com. With that said, thank you so much, Dr. Billard. I wish you a wonderful day in Chile, and we'll see you soon, hopefully.
Good to see you, and good to see you guys all. Let's keep in touch.
All right, take care of yourself, Doc. Thanks.
Take care.